Right, Dr. Khan, it is pretty close to 9 a.m. Friday, March 14th. If you're ready, we can go ahead and start.
Yeah, yes, I think you're ready. So, as most this is Dr. Khan, Chairman of the Patient Protection Commission. I call the meeting to order, and we'll start with the roll call. Mr. Filippi.
Yes, thank you, Dr. Khan. Joseph Filippi for the record. So just to make sure we have a majority of members present today, I'm going to start with our voting members. Please just let me know if you're present today when you hear your name. Commissioner Jalen Behunin.
Present.
Thank you. Commissioner Dr. Bio Curry-Winchell.
Present.
Thank you. Commissioner Davis.
Present.
Thank you. Commissioner Flo Khan is traveling at the moment, so we're going to mark her absent excused. Commissioner Marilyn Kirkpatrick.
Here.
Thank you. Commissioner Bethany Sexton.
Present.
Thank you. Commissioner Dr. Mark Glyman.
Here.
Thank you. And Dr. Adam Parath.
Here.
We're going to mark Andrea Peterson absent excused as well, and Dr. Ikram Khan.
Present.
We do have majority of voting members present. Just want to note who we have as far as our ex officio non-voting members, starting with Insurance Commissioner Kipper.
Here.
Thank you. Director Richard Whitley from Health and Human Services is going to be absent excused today. And we have Executive Officer Celestina Glover?
Here.
Thank you. And Executive Director Russell Cook from the Silver State Health Insurance Exchange. We'll mark him absent excused as well. Dr. Khan, we do have quorum. We can go ahead and move forward.
Thank you. So we'll proceed. Our next item on the agenda is for public comment. Can you brief the folks, Joseph?
Yes, thanks, Dr. Khan. Joseph Filippi for the record again. So anyone participating who'd like to provide public comment this morning, if you're joining by phone, the phone number is 775-321-6111. When prompted for the meeting ID, please enter 823-807-79#. And so if you're joining by phone today, you can press *5 to raise your hand. Let us know that you'd like to give public comment this morning. If joining from the computer, just hit the raised hand feature at the top of your Teams platform. Any public comment today will be limited to 3 minutes. And I'm seeing a hand raised from Renee Ruiz. Please go ahead.
Good morning. Thank you. Again, my name is Renee Ruiz. I am Government Relations and Community Organizer for National Nurses United in Nevada. And I observed on the agenda discussion about SB 34, the nurses licensure, among many other compacts. In the legislative update today, and I just wanted to stress again, we were here a few months ago talking about how we very much opposed, and we provided much evidence for the reasons why we opposed, such as there are plenty of nurses to fill the positions in the state. The problem is working conditions, lack of safe staffing ratios, lack of respect on the job is what keeps nurses from the bedside. It's not flooding the state with more licenses. Anyway, I provided an updated with 2024 data to Mr. Felipe, and who was going to put it in the packets for folks this morning. And again, I just wanted to use my time today to say once again, National Nurses United, who represents more than 3,000 nurses in the state of Nevada, is completely opposed to nurses licensure compact. Thank you.
Thank you very much. Appreciate it. Anyone else for public comment?
Not seeing any additional hands raised. Again, if you're joining by phone, please press *5 or raise your hand through the Teams feature. Dr. Khan, I'm not seeing any additional requests for public comment at this time.
Thanks. We'll move on. to the next item on the agenda. This is for information only. We will introduce our new member to the commission, Dr. Adam Pora, who is a licensed pharmacist, recently appointed. Dr. Pora, you're welcome. Number one, could you let us know a little bit about yourself?
Yeah, I'd be glad to. So, I guess for the record, Adam Porath. I'm the vice president of pharmacy at Renown Health in Reno. I actually am born and raised in Reno. Went to pharmacy school at Idaho State University up in Pocatello, Idaho. Came back to Reno, did my residency at Renown, and have been in a variety of roles ever since. I started in critical care, and then eventually for the last 5 years have been working mostly in hospital administration. I've been very involved in the last probably 15 years in scope expansion for pharmacists within our state. We utilize pharmacists as provider extenders in our organization and are looking to really leverage the expertise of pharmacists. I currently serve on the Nevada State Board of Pharmacy. I was appointed last January to that position and am their treasurer.
Thank you very much. Welcome again. Going on to our next agenda item. This one is for action. Approval of the minutes from December 13, 2024 meeting. So I presume everybody has had an opportunity to read the minutes. They were sent earlier. If so, unless somebody has any questions, additions, or subtractions, I would request a motion to approve the meeting or the minutes.
Motion.
I'll second. This is Bethany Sexton.
Thank you. Any opposed? If not, the motion carries. Thank you. So the next item on the agenda is again informational only. This is the update
Dr.
regarding
Khan, sorry. The last agenda item was actually to approve meeting minutes from December and January's meeting. I think we just motioned to
Yeah, I
approve
missed
December
Jan.
meeting.
Let's
Yeah.
include the two together.
So we might need to do another motion for both dates.
Yes,
I apologize.
So is there a motion to approve both minutes?
Motion.
And the second again.
Thank you. Any opposed? If none, so that carries. So the next one, item on the agenda is informational update regarding Nevada health insurance claim denials, data and mental health parity and addiction equity act compliance. We have allocated 20 minutes, 15 for presentation and 5 for questions. And I appreciate our insurance commissioner, Scott Kipper, joining us, and please kindly let us know what update you would have.
Thank you, Chair Khan and members of the committee. For the record, I'm Scott Kipper, and Nevada's insurance commissioner. And I want to touch on actually 3 topics today. One, of course, is the concept of what's going on claim denials in our state. Then also address what the division is doing here on compliance with MHPAEA, the Mental Health Parity and Addiction and Equity Act. And then I've asked our insurance regulatory liaison, Adam Plain, to provide some observations on some of the health insurance related legislation that's been introduced. And we certainly would be anxious to provide information and then look forward to answering any questions that commission members might have. Let me jump into the claim denial topic. Let me start by saying that the division in the state here does not collect specific Nevada data. The information I'm going to share is from our National Association of Insurance Commissioners on a national basis. I have no reason to think that the Nevada experience would vary greatly from what we're seeing on a national level. This information is collected through a concept called the Market Conduct Annual Statement, which is a data call that is provided to all carriers in the country. It is, again, collected at our national organization, consolidated and distributed. I think the key number here is that the number of claim denials to the total number of claims received, and this is excluding pharmacy, is roughly 15.7%. Now, the reason for those denials could be out of network, could be not a covered benefit, but that number is, so 85% of claims that are submitted are reviewed and paid according to the terms of the contract. Some interesting other notes that the percentage of in-network claims paid within 30 days is 96%. The percentage of claims paid for pharmacy only is 75%. I find this really interesting. The number of adverse determination grievances, that is, those who've gotten a denial for a benefit per 1,000 member months is 1. So 1 adverse determination grievance per 1,000 member months. The number of adverse determinations overturned to the total grievances is 36%. In other words, almost 1 in 3 of those who grieve an adverse determination is overturned, which I think is probably telling, and something that the division will be encouraging consumers to make sure they review, and if they have an adverse determination, to make sure they follow through on their rights as extended to them under the terms of their contracts. One final ratio that I'd like to share is the ratio of customer requested appeals on final adverse determinations to an external review organization. Again, this is the ERO, or external review organization, is the next level of appeal beyond when a company denies the claim. It is appealed to the company. They do a further review. If there's a subsequent denial, consumers still have an additional right to go to and request a further review by an external review organization. And the number of those requested appeals per 1,000 member months is 0.029. So very small number of customers do take their appeals to the final level. Once those go to an ERO, the determinations upheld is at 59%. So I guess the point of all this is that there's a number of different levels. And one thing I didn't mention is that the Division of Insurance does have a fully staffed consumer affairs section. So if a consumer does feel aggrieved by the actions of an insurance company, they can appeal and file a complaint directly to the division. The division will investigate, advocate to make sure the terms of those contracts are provided for and the consumers receive the benefits that they've anticipated under the terms of the contract. So Chair Khan, I will stop at that and try to answer any questions we might have on the claims denial concept here in Nevada.
Thank you very much. So I would request the commissioners to chime in before I ask my own question. So Joseph, could you kindly follow through with the commissioners who have questions.
Yes, Dr. Khan. Joseph Hope for the record. Dr. Glyman, please go ahead.
Thank you very much, Mr. Kipper. I really appreciate the work you're doing and the division. It's very important, and we're very grateful to have you. My question is, how many states do not compile the information or data on claim denials?
That's a great question. I don't think that there are any states that do not participate in the market conduct annual statement program. I think that this is a uniform national approach.
So is your feeling that our state is similar in terms of the denial rate as the rest of the country then?
That's my sense. I know that our marketplace, well, I would say all 50 states, the District of Columbia and the territories all have a similar regulatory structure. They're not exactly the same. So there may be slight variations in the numbers from if states were to do this on a state by state basis, but I have no reason to believe that we would be extraordinarily different than the rest of the country.
Thank you.
Thank you. Who's next, Joe?
Dr. Parth, go ahead.
Yeah, thanks. Scott, you mentioned roughly an 85% paid claim rate for medical claims. Did you share any data around those that go through successful appeals? So eventually, like those that get through the appeal process, what is the total rate of paid claims?
I think that number probably includes or is roughly close, again, that 15% of the denials. If one would go through all the appeals process, might tip that number, slightly up. But I think that the denial rate of 15% probably would not change a great deal, taking all the rest of the appeals process through. I guess so. What I'm trying to say is, where it sits at 15%, perhaps that number might go to 14.5% if you take into account all of the successful appeals. So it's a very small number that I think that would change.
Anyone else or any other commissioners have a question?
You can go ahead, Dr. Khan. I'm not seeing any additional hands.
Okay, thank you. So I have a couple of questions. So what you mentioned earlier in your presentation is the procedural part of it. Ultimate denial versus initial denials. What happens is you do an initial denial at whatever level of service, outpatient physician provider versus hospitals or any institutions. That comes in quick. Denial is very quick across the board, 24, 48 hours max. So then you go into appeal. The provider, the physician, or the hospital then has to submit an appeal to overturn. I don't know whether you're aware, the initial denial comes by a nurse. And the initial denial, as you may have seen in the New York Times article, is now coming through an algorithm that the companies have created. They feed this information into the computer, and if it doesn't fit into the algorithm, we don't know who created the algorithm. That gets denied based on the algorithm. So it doesn't even go to a human to look at it. The next level usually goes to a nurse. And then the nurse invariably upholds the first algorithm denial and then supposed to escalate it to a medical director. This whole process itself takes several days. Invariably, the medical director upholds the original denial of the algorithm/nurse, and then the regular appeal process that you're alluding to, where the patient has the right to appeal through the next level and the next level and the next level. And there are those 3 levels according to our commission guidelines that patients should be allowed. The challenge I see is, for example, a physician orders an MRI on a patient and it is denied. It may take days and even weeks to go through this whole process. And when that happens, this patient is sitting there in agony, not knowing what's going on, especially in a cancer diagnosis or potential cancer diagnosis. And it goes on for days and days and days. And at some point, the provider, the physician, he's busy. I mean, he's seeing patients, or if it's a surgeon, he's operating and may not be able to keep up the pace to call back and forth and back and forth. I have had examples in my practice, and even now when I review cases for denials, non-denials, etc., that the patients just give up. And those are the stories that were revealed in the New York Times article a couple, 3 months ago, is that the patients give up. And some, if they are desperate and the condition is potentially serious, they'll pay out of pocket and move on. So it is this delay process that takes forever, which I, as a patient protection commission by definition, the patient is not protected from going downhill in the diagnosis of his or her condition and puts the provider in undue burden to keep dropping his work and wait for a doctor on the other side to come online. And if and when that doctor comes online, then discuss the whole case. If it is still denied, this doctor's time is wasted. The provider is frustrated. What do we have in place? Are there any guidelines? How promptly all this should go? In my opinion, the process should not take more than a few days. Like the denial comes in 24 hours. Why the reversal of denials or non-reversal of denial may take days, weeks, or longer.
For the record, Scott Kipper, Dr. Khan, that's a great point, and it's one that we have really worked on internally here at the division. The division has provided an opportunity to create a bill for the BDR for the legislature. It's normally a kind of large catch-all because we're only limited to one. But this year we felt that the provisions surrounding the issues around prior authorization and timelines and timeframes in Nevada probably need to be updated. The original language dates back probably 30 to 40 years, where prior authorization carriers had 20 days to make that determination, as you were just so succinctly laid out. In this day and age, with the advent of really rapid technology, we believe that that time frame needs to be shortened significantly. Interestingly, as well, and unrelated to what the division had proposed, the governor did mention in the state that prior authorization issues were also something that the executive area of the governor's office is looking at as well. We proposed that that 20-day period be shortened to 5. And in the case of an urgent issue, 48 hours. And we hope that that will address the challenges that the patients particularly are being subjected to.
This call will be recorded.
So we really do hope that
this call is no longer being recorded.
We really do hope that those provisions will be adopted in some form from whatever bill advances, because we think that's great consumer protection.
So just following up on that, for example, Patient is in a hospital, needs to go to a facility, acute rehab or long-term acute care or nursing home, and various different companies have different rules. So if this authorization to go to another facility is generally not received for 2 to 3 to 5 days, and this is my personal experience every day. The patient sits in a hospital exposed to potential hospital-acquired infections for that period of time. Most of this happens in a DRG patient where they give a lump sum payment to the hospital for the entire stay. So basically, the insurance has no concern about delaying the authorization because technically they're getting free service at the hospital anyway. And in the end, they come back and after 5 days, they deny the stay. The hospital patients are staying there longer in the acute care facility when they really should not be there. The emergency rooms are backed up because these patients, 20, 30, whatever a day, are sitting there waiting for authorization. You wait 4 days for authorization for acute rehab, that's denied. Then you start all over again and request a nursing home facility, that's another 3, 4, 5 days. This is just, to me, just not acceptable. I mean, it's trying to protect the patient. This is not patient protection. Something has to give.
And we agree, and that's why we recommended the shortening of that authorization period to something a little bit more reasonable, particularly given the level of technology and interaction between carriers and providers these days. I just think that's so important.
I would suggest it should be no more than 24 hours. Like you said, in this day of technology, there is no reason. I mean, when it was paperwork, I can understand. So this is my serious concern of patients' access to service in a timely manner. It's just like justice delayed is justice denied. Patient services delayed is services denied. Difference is here human life is involved and endangered. Injustice is a little different. Any other commissioners have any comments?
Dr. Bio-Curry-Winchell, please go ahead.
Yes, Dr. Bio-Curry-Winchell for the record. I want to second what was just mentioned. When we talk about, as a practicing physician myself, hearing that there is an algorithm and then a nurse reinforces that algorithm and then eventually it goes to the medical chief officer. Well, for us as clinicians, we are treating our patient and our patient may be getting worse, or there's no way to intervene while we're waiting for this authorization. And so I recommend that we really need to dissect every single layer. So I hear how you're sharing, the 5 days and reducing that. But even if you reduce it, as Dr. Khan mentioned, that doesn't delay the possibility of a poor health outcome, because as that patient is waiting for the care or intervention or possibility to be moved to a different location, there's an increased risk of infection. There's a delay of care. And when we rely on an algorithm that is not individualized, that is not really looking at that patient care, we have also increased that delay. And so I want to provide support to him as he's mentioning that, for us as doctors, we are in the front lines trying to see our patient, but be beholden to a algorithm and then a process that is delaying the care that we are trying to deliver to our patients needs overhaul, needs to be efficient, because we are dealing with a human life, with a person's life.
Thank you very much. Any other comments from other commissioners?
Bethany, will go to you and then Dr. Glyman.
Thank you. Just wanted to add a couple of notes from the insurance industry in terms of there are requirements today around turnaround time. So as an example, CMS has requirements that many insurers adhere to around 72 hours for urgent, 24 hours for biomarker testing and others. So there are standards on the industry today. The second thing I just wanted to ask Commissioner Kipper if I could for clarity around some of the denials that you were talking about. And those, I guess my question is, are those are denial rates on claims specifically, not on authorizations?
For the record, Scott Kipper, yes, Bethany, that's correct.
Okay, and then I guess the second part to that question is just when those stats are being all inclusive across all types of claim denials, or were those specific? So might they also include scenarios where members were not even eligible on the plan, or it was a non-covered service, in addition to potentially authorizations or other things that might not have been appropriately completed?
Again, for the record, Scott Kipper, and I think that is absolutely accurate.
Okay, thank you. Appreciate that.
Thank you. Dr. Glyman, you were next, I think.
Yes, thank you again. This is Dr. Glyman. You know, as a practicing surgeon, I think I'd like to support what Dr. Khan's saying. You know, going through the Sunrise emergency room any morning, it looks like you're almost in New Delhi. And I'm not specific to Sunrise, everyone's like that, but I've gone there in UMC and every one of the other trauma facilities, and people are stacked up in the halls waiting for beds in the hospital. And it's sort of unacceptable that you have family members in such close proximity. And even if you go up onto some of the wards now, the wards are now places where they're doubling up single patient rooms to take care of patients because they're running out of space, or they're taking waiting areas and they're putting 10 beds in there to house patients. So it's not, I think there's an issue here that is a little bit more nuanced in terms of taking care of patient care. And it all starts with what Dr. Khan's saying is that, and I'm not being critical of the insurance companies at all, but there is some algorithm that we found out was happening with the senior patients with the unfortunate incident in New York, where these algorithms were immediately denying people care. And the care that trying to get people out of the hospital into other tertiary care centers is important. It's important. And I think that if we can support this as a commission, your bill to try and shorten these times of authorizations, I think that would be critical in terms of freeing up the hospitals and also helping them financially, because the bottom line is a lot of these hospitals, even if they're for profit, are not making profits and they're losing money. And, you know, it's a very difficult situation. And I think that your bill is important, but I think we should look at those times and see if those actually in this day and age are as important, or we should push them to be turn around a little bit faster. Thank you.
Thank you. Anyone else?
Not seeing any additional hands raised. Mr. Kipper, I just wanted to ask what bill number you're referring to, and I'm not sure if Adam was going to go over that. You mentioned he was going to share some legislation updates.
Yeah, I will leave it to Adam. He's far more versed in the number of bills that are addressing prior authorization. But I might touch on one additional item. Our national group, the National Association of Insurance Commissioners, 18 months ago, drafted a model bulletin for use by states addressing the use of artificial intelligence, in particularly in this manner. Basically, the bulletin puts the onus on the insurance companies to, if you are using an algorithm, i.e. artificial intelligence, to make determinations. And it's not just in claims, but other parts of the insurance spectrum, that if you are using those, that they must comply and must comport with state law. And any variation from that would be deemed an unfair trade practice. So there is notice to the industry that the use of these algorithms to unfairly discriminate against consumers is front and center. Nevada was one of the early adopters of this bulletin. I believe now that there are over roughly 30 states that have also added this bulletin. So it's something we take very seriously here. If we get reports of such, then we certainly would investigate and make sure that carriers are indeed not unfairly discriminating by the use of these algorithms.
Thank you, Commissioner Kipper. I have one additional comment. I personally would be primarily interested in clinical denials, no medical necessity, etc. Technical denials, one doesn't have an argument, it's not covered benefit, etc., etc. That's fine. It's the medically not appropriate language that's why we are denying it. So that's the key number really in an ideal setting. Number two, what can be done to let the consumers know that they have an option to go to your office to get a resolution? They give up more than half the time with the insurance company itself. After a month or whatever, they said, forget it, and they've gone another route. So is there enough knowledge about the potential access to your office for resolution of these matters?
For the record, Scott Kipper and Dr. Khan, you make a great point. We try very hard to make sure that consumers across the state know that they have a division of insurance to turn to when they have questions, not only on health insurance, but all forms of insurance, or if they have all forms of any form of question or concern, that look to us as a fountain of knowledge. And if they need an advocate and they believe that they've been wronged, to file a complaint and allow the division to do some investigation on that. We try very hard to make sure that that level of publication to the consumers is broad. It's an ongoing battle. We even still, after all the work that we've done and have our website, of course, that we still get questions or comments saying, gosh, I didn't even realize you all existed. So this is an ongoing challenge for the division and for the state to make sure that consumers know they have a place to turn to.
Dr. Bio, sorry, Dr. Bio-Curry-Winchell had her hand raised. Dr. Khan.
This is Dr. Bio-Curry-Winchell for the record. Thank you, Scott Kipper. I was going to ask the question, what sort of mediums have you been utilizing to get the word out? I can share with you, a lot of my patients have no idea that they have this extra opportunity to appeal or go to your office. And so we are in the current climate where social media, other forms of media are utilized and consumed to educate. And so that was going to be my question. Are you, what forms of media are you utilizing to get the word out so people know? Because the old-fashioned pamphlet or tiny word writing is no longer really in fashion. So I was just curious to kind of find out what you're using to get the word out.
For the record, Scott Kipper, and thank you, Dr. Curry-Winchell, for the question. We are at the agency here really ramping up our social media presence and the issues that we support. Of course, we're on Facebook like everybody else, but also LinkedIn. And we've doubled the number of entities that follow us. But in terms of absolute numbers, we still have plenty of room to grow. We have done public service announcements in the past, but given the changing ways that consumers consume information, we're looking at better alternatives than television or radio to get that message out. It's an ongoing challenge for us, and we would love to work with the State Medical Society, the Patient Protection Commission, State Hospital Association, any entity that represents the health providers industry in the state to see how we can get that message across.
Anybody else? Joseph?
No, Dr. Khan, I'm not seeing any other commissioners. I did have a really quick question. Mr. Kipper, you mentioned you're willing to work with other agencies. Just curious how you currently interact with the Office of Consumer Health Assistance.
you know, we do have within the Department of Business and Industry a consumer liaison. And we work closely with them, of course. We would be happy to entertain working with any consumer focused entity within the state. We just need to expand on what we're doing right now.
Thank you.
So, a comment to reach the providers, so they are also advocates for the patient. That is easy to do. There's a medical licensing board for osteopathic physicians, MDs, nurse practitioners go through the nursing board, etc. They have their regular bulletins, news bulletins for their providers. All they have to do is put in a couple of lines that in this situation, please call the right to the insurance commissioner's office if you have any concerns about lack of access for the patients, your patients. So the providers, they need to do, it's the consumers. So I think we need to move on unless somebody else has an additional question.
Not seeing any, Dr. Khan.
Okay, great. So we move on to the next item of the agenda. There's agenda number 6 for possible action. Joseph, you want to take it up?
Yes, give me one moment to pull up my slides. Thank you, Mr. Kipper. Oh, sorry, Mr. Kipper. Before we move on, did you have Adam needing to provide a legislative update?
We can do that, and we could push our report on the mental health parity and compliance to your next meeting. I think there's some value in sharing that story with the commissioners, but I would turn it over to Adam to give a brief legislative update.
All right, thank you, everyone. Just keeping this brief due to time constraints. Dovetailing in with the conversation we've just been having, I wanted to mention to commissioners and interested parties, specifically the conversation earlier about the divisions bill relating to prior authorization. You're looking for Assembly Bill 74 on that regard. But as we're talking about authorizations and adverse determinations, I would bring to the Commission's attention 2 bills, Assembly Bill 290 and Assembly Bill 295. And they both deal with adverse determinations in reporting, and they take different paths to get to a spot that would interest the Commission, and that is public reporting of data related to adverse determinations. So it would require, one bill would require insurers to report adverse determination data directly to the commissioner, who would then aggregate it and publish it in a way as to not reveal trade secrets or release any personally identifiable information. The other bill, Assembly Bill 295, would require insurers to publish their adverse determination data on their own web page and also transmit it to the Commissioner of Insurance and the Department of Health and Human Services for publication on their websites as well. I do believe that Assembly Bill 295 is geared more towards the issue of the use of artificial intelligence in adverse determinations, whereas Assembly Bill 290 is just adverse determinations in general. But I would recommend anyone who's interested in the topic take a look at those 2 bills in particular and determine whether they're worth interacting with the legislative session on, if they meet your interests. And keeping it short, if there's any questions on those 2, I'd be happy to answer them.
Thank you, Adam. I'm not seeing any hands raised. Really appreciate that update. Dr. Khan, since we have both Mr. Kipper and Adam present today, I know they're very busy as well. Not sure if we want to have them give an update on the Mental Health Equity Parity Act, or if you want to push that out to a future meeting.
Depends how the commissioners feel. We have a few items to go. What's your guesstimate on completing those in a timely manner?
I can give you
next level, next meeting, if it's okay with everybody else.
I think Mr. Kipper said it would be pretty short update, but
Oh, okay.
I
All
can
right,
do
then we
this very briefly. NRS 687B of .404 does require insurers or other organizations providing health coverage to comply with the Wellstone Domenici Mental Health Parity and Addiction Act of 2008. Further, NRS 687-404.2 requires the division and the commissioner honor before July 1st of each year to prescribe or provide data necessary to make sure that there's compliance by an insurer. Finally, in that same section, does require the division to report on or before December 31st of each year a report summarizing the compliance with the MHPAEA Act. The division last year did an initial data call. The data came back relatively unusable and poor, so that the division felt that we had no choice but to do a second data call. We performed a second data call, and the information that we got back indicated that there was a significant level of challenges by carriers complying with MHPAEA. The division has indicated that we are in this report that we are going to begin desk audits or exams of all carriers that are working in the Nevada marketplace on mental health parity. We have started those exams. We will continue those through the course of this year, and will probably bleed over into 2026. We again will have a preliminary report later this year, but this I think is a real challenge based on what we've seen so far for carriers complying. My initial sense is that the adequacy of networks is a real challenge, just simply because there's not enough professionals that are in those networks. So, Dr. Khan, that's a very brief statement of what we are, where we were, what we've done, and where we're headed with this. So please stay tuned as the division works through these exams and in order to substantiate compliance.
Thank you very much, Commissioner Kipper. Any comments on this? Joseph, do you see
not
any
seeing
hands?
not seeing any requests. Just wanted to thank Mr. Kipper for that update, and also mention that that report that he mentioned that's coming later this year, in statute, it says that report should be submitted to the commission as well. So whenever that's finalized, I'll be sure to share with commission members for their review, and just again appreciate your time, Mr. Kipper.
Thank you all.
Kipper, very much. I know you're very busy with the legislative sessions on. So I personally also, on behalf of the commission, thank you for being here. Thank you.
My pleasure.
Thanks. We can move on to the next item. Joseph.
Thank you. Thank you, Dr. Khan. Yes, Joseph Filippi for the record. So moving on to agenda item number 6, it is for possible action. This kind of dovetails on a previous meeting we had in January, where we received an update related to Assembly Bill 7 from the 2023 session and the regulations recently adopted by the Division of Health, Finance, and Policy. And so really this stems from in statute, the commission is required to submit an annual plan to the director of the Department of Health and Human Services to increase the access to patients' medical records. And so when I first took this role and I was reviewing the statutes that require us to do certain things, I noticed that this is really closely related to that bill that passed last session and the regulations that were recently adopted. And so In discussing with our Deputy Attorney General, he agreed that the Patient Protection Commission could consider just recognizing the recent regulations that were adopted in response to that bill. Really recognizing that it meets the intent of the statute that's requesting our commission to develop a plan. So really, if the commission is willing to today, could vote to recognize these regulations as meeting the similar intent of our annual plan that we're supposed to develop, which would thus remove our responsibility to create such a plan. And just for a little historical background, the commission has not created a plan related to this requirement in the past. I believe in 2022, there was a few meetings where a plan was drafted and discussed, but nothing was really formalized. And so just wanting to bring this all to your awareness and have you all discuss and consider recognizing these regulations that were adopted from the agency as meeting the intent of this statute.
Hey, Joseph, if I could just add one thing.
Sure.
I know I did work with you a little bit on deciding that we would go forward with this route, and it made sense for us to do so for a bunch of reasons, I think. But if this commission decides, they could, of course, decide not to recognize this as meeting the requirements. Additionally, if you guys want, you could, you're supposed to do this initially and then an annual update, I believe, as necessary. And you could, of course, decide to implement it, but still have additional concerns or questions and want Joseph to put something else on a future agenda.
Thank you. So any comments on that? Any hands raised, Joseph?
Commissioners, do you have any comments or questions about the agenda item before you? Not seeing any hands raised.
So then I think since we need, this is an action item, so we would need a motion to consider this, as the JAG has also pointed out, and Joseph detailed this. Who would want to take the lead to make a motion to suggest that the current presentation as complying with the requirements?
Dr.
Bethany.
This is Marilyn. Oh.
Sorry. I just saw Bethany had her hand raised. Marilyn, sorry. Did you have a
Sorry,
question?
Yeah, I do. I'm late on raising my hand. Just a question. I want to make sure that we all understand what's in AB7 and how it actually ensures that we're meeting this requirement. So I didn't see that was necessarily provided in the materials, but maybe others feel like they're better versed on AB7 than I might. So I just want to make sure we understand what it does.
This is Joseph for the record. There's actually a presentation last meeting on that bill and the regulations that were recently passed. Bethany, I don't recall if you were in attendance that meeting. Happy to provide those materials. Really what the bill does is it requires providers to adopt, it has regulations around a framework for providers to participate in health insurance exchange and information interoperability. I'm not sure if we have a member from Medicaid who could give more specifics on that. But yeah, I just assumed that the presentation last meeting would have covered that background information.
Thank you. I can go back and reference it. I don't think I was in attendance. I'll go back.
So what is the will of the commission? Should we table this till everybody has had a chance to review it? Or would you folks like to vote on it today?
Dr. Khan, this is Marilyn. I can go either way. I was going to make a motion to go forward. What I can tell you, speaking with the original person who helped create the Patient Protection Board and the bill that passed and the regulations to make it more robust, I feel like we're doing yeoman's work. And there's a couple last years, but I think that those regulations are within it. But I'm happy to table it if everybody else wants to wait.
Will of the commission. Anybody opposed to tabling it? Let's do it that way.
This is
Joseph?
Commissioner Davis. I recommend that we table it too, so we could have a better appreciation of the bill, of the information.
Perfect. So can we have a motion to that effect? To table it?
I'll make a motion to
This is
table
Commissioner
it.
Davis. I second. Mr. Davis
Perfect.
second.
Any
Hey.
opposed to tabling it? Joseph, you see anybody's hand?
I do not, Dr. Khan.
Okay, so then we would consider this motion carries. Thank you very much on the subject.
Joseph?
Jo-
I'm sorry,
Yes.
Dr. Khan. Could I just interrupt just quickly? I think it's fine for us to table it, but I just want to make sure, what are the deadlines for us as far as the commission actually taking action on this? I know that it does talk in statute about they're supposed to do it and then annually update. You're telling us that they've not done it before. I'm not sure when this particular task was assigned in the statute. Could you tell me if there is a deadline for the commission on this?
This is Joseph Filippi for the record. There's no date identified, Gabe. It just says that the commission shall adopt and then annually update a plan. And this legislation was originally passed, I believe, in 2021. So like I mentioned, it hasn't been formalized at this point. I will make sure that a representative from Medicaid attends our next meeting and can speak to the regulations in more detail.
Okay.
Apologies
Yeah,
for not
think
having them today.
That's helpful. Thank you, Joseph. I think it's fine tabling it, especially since it's been a while anyway. I'd rather have the commission vote on something that they're fully cognizant and knowledgeable about. And for the representative, if at all possible, if you can make sure it's Melinda, that she'd be the best to be present. All
Will
right,
do.
thank you.
Thank you very much. So we had already carried this motion. Thank you for that additional thought. Let's move on next to the agenda item 7.
Thank you, Dr. Khan. Joseph Filippi for the record again. Item number 7 is informational, just providing you all with a quick update related to the 3 bills that we've submitted for the 83rd Legislative Session to consider. As you are all aware, those bills are Senate Bill 29, Senate Bill 40, and Senate Bill 34. Unfortunately, I don't have a ton of update to share with you. We are still waiting for our bills to be scheduled for an initial hearing in the policy committee that they've been referred to. So as this slide shows, SB 29 and SB 40 have been referred to the Senate Health and Human Services Committee, and then SB 34 relating to the interstate licensure compacts has been referred to the Senate Commerce and Labor Committee. I've made contact with both of the Senate committee chairs, just requesting that these bills be scheduled for a hearing. And in addition to that, Dr. Khan submitted a letter to the chairs requesting their consideration as well. And we're currently in day 40 of the 120-day legislative session, so about a third of the way in. There is a deadline coming up next month on April 11th, which means that, so any bill that doesn't pass out of the initial policy committee in the first house that was referred to would die on April 11th. So we have a little under a month for these bills to be heard at their policy committee hearing and then referred to the floor and to the next house. I will also note that all of these bills have been, there's been a fiscal note associated with them. Majority of the fiscal notes are coming from the Medicaid agency. The compact bill does also have a fiscal note from some of the licensing boards that would be impacted by this. So I believe, you know, if these bills were heard, they would then be likely referred to a finance committee to then discuss the fiscal impact later on in session. So that's really the only updates I have related to these 3 bills, and happy to address any questions that commission members might have today.
Thank you, Joseph. Any comments or thoughts from the commissioners?
This is Marilyn. I do have one. I do think that this is the whole reason of this meeting, is so that we could independently kind of ask if they're going to be heard or see what the pleasure of the health board is. I completely understand that they have fiscal notes and that they'll be part of the end game, but they still have to get out of the policy committee to get to the finance thing. So So I'm just wondering if it's just a reminder that we make sure some of these bills get, just a reminder to the legislature that they're important and they're bipartisan.
Just thought, Joseph, our second director, has kept me abreast on these developments. As he mentioned earlier, I've also sent letters to the chairs of the committee to show them in writing that we are interested in following this. And I think Joseph has his finger on the pulse on this. So yes, to your point, we are following it closely. And should there be any developments of concern at some point, he'll bring it to us. And if we have another meeting in the interim, we'll hold it.
And I will just mention, as a state employee, I'm not a lobbyist, so I can't meet with, I can meet with legislators and kind of inform them why the commission are proposing these bills and why you've all mentioned they're important for addressing the workforce challenges we face. But as we've discussed previously, I believe, and I think what Marilyn is hinting at is that if individual commissioners would like to speak on their own behalf, not on the behalf of the commission, but would like to contact individual legislators to, voice their own thoughts and wanting, lawmakers to consider these bills, you are welcome to do so. Just a reminder that you wouldn't be able to speak on behalf of the commission unless it's something we've formally agendized and authorized you to do so.
Yes. After the earlier is following that, and if something develops, we can talk about it. And like he said correctly, that then the individual commissioners can choose if they do to go to the committee as an individual.
So, Dr. Khan, I just want to push back a little bit because here's the thing. Here's what's always happens with healthcare. We have all these committees, we do all this work, and then nobody ever wants to make that extra call. No one ever wants to make that extra pitch. And then the bills fall by the wayside. And unfortunately, with term limits, now there's less institutional knowledge of what's going on. So I guess I'm going to ask. I asked for the March meeting so that we could know if our bills weren't being heard, that maybe we all know one person or one lobbyist that could just check in to make sure that I'm a little bit tougher because I'm going up there every other week myself, and I will just be beside myself if healthcare doesn't move forward this time. And I've been around a long time, and we talk about it, and then we don't ever do anything with it. So I'm just asking, you guys are a lot more powerful and smart than me on healthcare, but we're at a crossroads. We either got to do right by Nevada constituents or we got to stop having meetings is where I'm at. So sorry, I just had to get my passion out.
Very helpful. Certainly very helpful. Any other commissioners have thoughts on it?
I'm sorry?
Anyone else has any thoughts? In other words, how to follow this through, to your point, that they usually don't go anywhere, as Joseph alluded to earlier, and JAG has confirmed that in the past, that we as a commission cannot go and lobby, but as individuals we can. But if I remember correctly from previous meetings a while ago, it doesn't stop us agendizing an item to go over the developments that may be happening in the legislature. That's the value of these updates.
Thank you all. Not seeing any additional requests for comments. I think that concludes my formal updates on these bills. Like I've mentioned previously, I'll try to continue to update you on these bills and other health-related legislation as the session continues.
Thank you. And Commissioner Kilpatrick, if you have any thoughts or ideas, please do share with us because you have more experience than most of us here
Okay.
Thank you very much. So going to the next item for possible action, review and discuss PPC policy focus areas for 2025. This is also Joseph Filippi.
Thank you, Dr. Khan. Joseph Filippi for the record. So just a few slides to share with you. So this agenda item really relates to following our last meeting in January, a survey was sent out to each of you requesting you to review certain information related to what our state's rankings in different areas of healthcare and providing some recommendations on future areas of focus for the commission. So really the survey questions that were sent to you asked for your recommendations in several different areas. These are kind of the four main buckets. So priority areas related to healthcare delivery and payment, health equity and disparities, healthcare workforce challenges, as we've discussed a lot this past year, and healthcare cost containment. So in the first bucket, just reviewing some of the information that was shared to you and some of the recommendations that you provided. So on the left-hand side of the screen here, as it's shown, this is regarding to Nevada's healthcare system's performance. And our delivery system in the state, unfortunately, ranks 41st in the nation for overall performance. And this includes being ranked worst in the nation for prevention and treatment, youth mental health access, and healthcare cost growth. So on the right-hand side of the slide, it outlines possible areas of focus, and this is from all of your recommendations through the survey. Some of those areas on how to improve access and quality, of course, would be to improve primary care and preventive care access, improving women's health and reproductive care, behavioral health, care transitions, and patient safety. Additionally, there's recommendations to reward for better quality of care through payment transformation and developing a more robust healthcare delivery system. Under the health equity and disparities area, as far as our rankings go, we're 45th overall for access and affordability, and we have one of the highest uninsured rates in the country at 11.4%. Additionally, there are disparities in health outcomes. So for example, infant mortality rate is 2 times higher for babies born to Black mothers. So that's a racial disparity there. And then on the right-hand side of the slide, some of your recommendations as far as priority areas would be to increase access to care for the uninsured, decrease disparities in health outcomes for certain patient populations, and then increase physical access to care through transportation and other means. As the commission's well aware, Nevada continues to rank well below the national average when it comes to our healthcare workforce challenges and the number of healthcare providers in our state. As you know, every county in the state has a section of it, if not the entire county, at least a portion of the county is designated by the federal government as a healthcare provider shortage area. We rank 45th for physicians, 45th for nurses, 48th for primary care providers, and 33rd for mental health providers. So on the right-hand side of the slide, this coincides with, the recent PPC report that we submitted back in January of this year. We need to increase the number of providers. We need to improve the training for providers, and additionally, find ways to improve recruitment and retention overall. Additionally, our report identified the need to increase reimbursement rates for certain providers, especially those who serve the Medicaid population, and then also reduce administrative burdens in various ways. Sorry. Finally, the last bucket is related to the healthcare cost containment and affordability. So on the left-hand side, as shown, Nevada ranks 45th overall for access and affordability, and we do have the highest healthcare cost growth in the country at 8.9%. Additionally, the state ranks 46th due to the number of adults who reported avoiding care due to cost. So on the right-hand side of the slide, some of the recommendations you all had to discuss in the future is addressing issues related to healthcare affordability through examining the growing cost of drugs, promoting transparency for manufacturers, pharmacy benefit managers, and insurers, and then also analyzing available data concerning insurance claims to improve patient access and quality to affordable care. So this concludes the overview of the survey results and some of the areas that you recommended to focus on. There was also a document shared in your meeting packets, and it's also posted online that we can share on the screen as well. But really, this is just a start of the conversation for the future meetings as far as some of the areas that you all would want to focus on. We can keep this as a running list for areas to focus on in the future. We can add, remove, or revise some of the areas that are outlined. But just wanted to bring this information forward today for an initial discussion.
Thank you very much, Joseph. This is a quick comment. I served many years ago on the Healthcare Cost Containment Commission. These numbers are not much different than they were at that time, and that is at least over 20 years ago. So you can, to Commissioner Patrick's point, nothing moved or moves on issues of healthcare that is consequential. So go ahead, any thoughts from the commissioners?
This is Commissioner Davis. I appreciate the list, and I think I'm okay with going forward with it.
Thank you. So, Joseph, if I may suggest that maybe narrow down and the commissioners can give you some input in the interim before our next meeting to see where we can focus, hopefully with the thought that we can make a difference with our suggestions.
Thank you. This is Joseph Filippi. Bethany, go ahead, and then I'll go ahead and respond to Dr. Khan's comment.
That actually was going to be very much aligned with my comment. Just asking for perhaps some help offline where we could do like a forced ranking exercise to just really see what rises to the top. I know we've done that before. It's been helpful. Want to say thank you to, again, there was a lot of content and things that you brought together for us that I think really helped us to focus in on things that could make an impact. And to Commissioner Kirkpatrick's point, I think unless we focus on some very specific action-oriented, outcome-based items, we're going to continue to sort of spin our wheels. So thank you for pulling all the information together.
Thank you. Any other commissioners' thoughts? Joseph, do you see any hands up?
I do not, Dr. Khan. And just Filippi, as a response, wanted to thank my staff as well for helping pull this document together. And, we reviewed all of your comments, which you gave a lot of great feedback to the survey. So wanted to thank you all for your time and sharing your thoughts related to these areas. And in response to Marilyn and others, I agree. There's so much in the healthcare space that our state can focus on. And so narrowing down our focus for the next year or so over this next interim, ultimately leading up to our next opportunity to propose bills to the next session, I agree would be helpful. So I will work with my staff to get maybe an additional survey of some form out to you all, hopefully so we can rank some of these items as far as what rises to the top as the highest priority. I know there's so many areas of focus that we could spend time on. So just appreciate all of your feedback this morning.
Hey, Joseph, I know you did agendize this as an action item. Was there any additional action that you thought perhaps they should or could take today? Or do you want to just come back with the rankings, or was there anything else that you wanted them possibly to do today? Whenever there's an action item, I love it if they can, if there's an action they want to take, take it.
Thanks, Gabe. So I guess the action would be, do you all approve of this document as outlining, your feedback through the survey as potential areas, policy priority areas of focus? And then, of course, at a later point, we can dwindle this down to maybe some 1 to 3 areas that we want to really dive into over the next year or so.
Any thoughts from commissioners? So my view would be on this is that we have done one survey already and given our thoughts, but earlier, generally the commissioners thought they need to narrow down their thought process and come back on it. to be more narrowly focused and prioritize perhaps items that maybe we may be able to move forward in the future. Is that the correct understanding of the commissioner's thoughts that I'm summarizing?
Go ahead, Dr. Glyman.
I think that we can, thank you, it's Dr. Glyman. I think we can do more than one thing at a time. I agree with you that we have to narrow the focus, and I think Joseph, you and your staff did a beautiful job on this draft, and I think it focused that down. And I think my opinion would be to send this draft out to all the commissioners and see if we can narrow it a little bit more down. I understand the issue with 3 bills for the next legislative session, but I think that there are other ways that we can protect patients other than with these specific bills by going to certain of the other agencies and see if we can affect change in that manner too. So I agree with you that there are ways to narrow this focus down for legislative session, but I think there's also ways to work with certain boards and certain agencies to push some protective agenda and let them be aware of that, of our concerns.
This is Joseph Luby for the record. Thank you for that feedback, Dr. Glyman. I agree that, our commission, we have the 3 bills, of course, that we're able to propose, but then, as you know, we can submit a report every 6 months to the legislature and the governor to consider. And ultimately, we can share that any of your recommendations with other agencies, boards, et cetera, as well. So definitely think there's a future opportunity there. Marilyn, please go ahead.
Thank you. And I was just going to reiterate that we also have the interim health committee where we can talk about some of those things. So the maternal health care for Black babies, that's public health. We can at least get other people. So if you prioritize them, then we could, maybe amongst all of us, we can have other groups start looking at ones. And then what, as the interim health, do we want to think about being the package for the next time, so that not only do we have it in a report, but we have real agendized conversations about it, so we can do the legwork in the interim.
Thank you for that feedback. I completely agree. It's a great suggestion as far as coordinating with the interim health committee.
Any other thoughts before we move forward, Joseph?
Not seeing any additional requests, Dr. Khan.
All right, appreciate that input from the commissioners. Thank you for that. Our next agenda item is a very
Sorry,
long...
Dr. Khan, before we move on, is there a motion, I guess, just briefly to approve the list as it is today? And then, of course, as we discussed, we'll have a more narrowed focused discussion in the future. Can we have a motion for that?
I move to approve the list as written, and with follow-up to narrow it down in the future.
Second.
Second.
All those in favor, please say aye.
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 Thank you.
Thank
Any-
you.
Not seeing any, any opposed? Okay, hearing none. Thank you all.
Any other things I missed on this one? If not, we can move to the next agenda item, number 9. It's a bit long item, review and approval of future meeting dates.
Sorry, thank you all. Almost done here. Thank you all for your time this morning. So this agenda item, as it says, it's another action item, review and approve future meeting dates of the commission. This is kind of just showing you an outline for calendar year 2025. So as it's proposed here, and I think I've mentioned these dates to you all as well, moving more to kind of a quarterly meeting outline here. Our next meeting, as this is proposing, would be June 20th. These are typically the 3rd Friday of the month, as outlined here. So that would give us one more meeting after the legislative session in June, right before our next PPC report is due on July 1st. And then moving on later in the summer, you all indicated you'd like to meet at least once in person. And so in speaking, trying to figure out, a preference as far as where commission members would like to meet. Majority of you indicated you'd prefer to meet in Las Vegas. I've had conversation with Commissioner Kirkpatrick, who has offered to host us at the Clark County Government Building. And so that is potentially where we could meet in person in August, and then later meeting in October, and then in December, when right before our report is due at the first of the year in 2026. So this is just a meeting outline for you all to consider and approve today. Of course, we can have additional meetings and reschedule these if the chair would like to do so at a later point, but this will just give us an idea on expectations and planning for that in-person travel later in August.
Thank you, Joseph. I would like to thank Commissioner Kirkpatrick for offering us that site for the future meeting. Do I have a motion to approve these dates for right now?
This is Commissioner Davis. I make that motion.
Is there a second?
Second.
Any opposed? The motion carries. Thank you very much.
Thank
So
you. And
that
just,
one-
sorry, just
Go
wanted
ahead.
to also mention
Go
as
ahead.
far as, sorry, thank you, Dr. Khan, Joseph Filippi. I forgot to mention that any commissioners that are willing to travel to the in-person location in Las Vegas, you all are eligible for receiving travel reimbursement. I sent an email out earlier this week, just giving you all instructions. In order to receive the reimbursement, you would have to apply and become a vendor with the state, just because any payments for travel reimbursement has to be done through direct deposit. And so I sent you all there's a online application that you can fill out to become a vendor. And I sent you information how to do so. If you have any questions about that process, please let me know. And of course, any commissioners who are unable to travel to the in-person site in Las Vegas, you will have a virtual attendance option as well.
Thank you for that information. So I think we move on to our next item of public comment. Joseph, do you have anybody in person or online?
Thanks, Dr. Khan. So this will be our second portion of public comment. So anybody, again, attending by phone, please press *5 to raise your hand. If you're joining by the computer, please raise your hand through the Teams feature. All public comments will be limited to 3 minutes. Please go ahead. We have a request from Travis West. Go ahead and please state and spell your name for the record, and you have 3 minutes.
Good morning, Travis West, TRAVISWEST for the record, Regulatory Policy Specialist with National Nurses Organizing Committee and National Nurses United, representing nearly 225,000 bedside nurses across all 50 states, including Nevada. Thank you, Chair Khan and members of the Commission. Our union has deep concerns about shifting Medicaid patients to accountable care organizations as contemplated by SB 29, as it is likely to incentivize providers to reduce patient care. While SB 29 is vague about payment systems, most ACOs receive a flat per person amount for a group of enrollees and include at least a doctor group and a hospital system. If the ACO provides care for less than this amount, they can keep the remainder as profit divided among participating organizations. But if they provide care that costs more than this amount, they incur a loss. While there are many variations on this basic model for capitated payments, all essentially rely on shifting risk from the payer or insurers to doctors and hospitals. In the standard health insurance model, health insurers get a set monthly premium and assume the risk if a patient is more costly than the premium. And in ACO, it is the doctors and health facilities that get a flat fee and assume this risk if they do not cover the cost of all the needed care. This is intended to create financial incentives to provide less costly care by emphasizing primary and preventative care and by coordinating care among the ACO participants. But it also incentivizes providing less care and shifting care to less costly settings and less skilled caregivers. Asking doctors and hospitals to bear insurance risk creates financial incentives to provide less care at great risk to patients. Decisions on care should be made by a patient and a doctor based on medical need and preferences, not based on saving money for an ACO. Moreover, quality metrics simply can't fix this fundamentally misaligned system. Value-based payment models, including capitated models, claim to incorporate quality metrics into payments to providers to ensure quality care. In reality, quality metrics frequently build in inequity through race norming and other mechanisms based on data created by systemically biased healthcare systems. Additionally, metrics-based incentive payments increase administrative complexity, wasting our doctors and nurses' time and rewarding healthcare corporations that can afford to find complex and sophisticated ways to manipulate the system. Thus, merely requiring an ACO to demonstrate that they can provide services in a manner that improves health outcomes and lowers costs compared to providers who provide similar care through other models will be insufficient. Cost and outcome measures are easily subject to manipulation, particularly by large providers, and gathering such data takes time away from providers that could be better spent on patient care. In sum, we have deep concerns about shifting Medicaid patients into accountable care organizations, that this will incentivize providers to skimp on care, resulting in worse health outcomes for the most vulnerable Nevadans. We therefore ask the Commission to reconsider promoting establishment of a reimbursement system for ACOs for Medicaid patients as contemplated by SB 29. Thank you.
Thank you very much for that input. Anyone else?
Yes, Dr. John Packham, please go ahead. You have 3 minutes.
Good morning, Chair Khan and members of the Commission. My name, for the record, is John Packham. I'm Associate Dean with the Office of Statewide Initiatives at the UNR School of Medicine. I'm also co-director of the Nevada Health Workforce Research Center. I just wanted to let the Commission know that as you assess policy in the current legislative session and as you lay out your priorities after the session is complete, feel free to reach out to my office if you ever need information on health provider trends, workforce shortages, and the like. I'm happy to speak to those. I tend to remain agnostic on some of the legislation. I'm not going to go near the mandatory nurse staffing ratio bill, for example. But I'm not going to be agnostic when it comes to the nature and scope of provider shortages and what proposed legislation might bring to those solutions. There are proposals that will move the needle on provider shortages. There's proposals that will get in the way of alleviating provider shortages. And again, I'm happy to speak to the data that's collected on an ongoing basis by my office. I've shared a nursing report on nursing workforce supply in the state with Mr. Filippi earlier this week as an example of the kind of information we can bring to bear. And I now have your commission calendar in my calendar now. So if you'd like for me to speak to any of those issues in the future, please don't hesitate to reach out. Thank you.
Thank you very much, Dr. Peckham. For those commissioners who are not aware, Dr. Peckham was a part of this commission initially and also was the chair of this commission initially. He eventually chose to not serve because of his other commitments. Any other comments or thoughts?
Again, if you're willing or if you're wanting to present public comment today, please press *5 or raise your hand through the Teams platform. Dr. Khan, I'm not seeing any additional requests.
Thank you very much. I think we call for a motion for adjournment then. This is one of the shortest meetings. I cannot resist commenting on the previous commission, not to negate the service of the commissioners. I don't remember meetings lasting less than 3 hours every time. So the fact that we are cutting down our meeting times, it seems that we are all working efficiently, and it's a great thing because everybody's time is important. Thank you very much. We stand adjourned. And was there a motion to adjourn?
Is there a motion to adjourn?
So moved.
Second?
Second.
Any opposed? None. Motion carries. We stand adjourned. You all have a wonderful weekend.
Thank you all. Appreciate your time today.
Thank you, everyone.
Thank you. Have a good day.